good evening, or good afternoon, depending upon where you're at. Thank you so much for joining us today. My name's Karen Sudders. I'm the Director of Nutrition for Medtrition, and it is my absolute pleasure to have you here to join us for a very creative webinar tonight. We are talking about creating awareness regarding the importance of nutrition in wound care, an expert discussion. We have today with us Dr. Carolyn Fife and Dr. Nancy Collins. As a few reminders, this is not for continuing education credit for any healthcare professionals, and the program itself is supported by Medtrition. So let me introduce you to our panels. Dr. Carolyn Fife completed a family medicine residency at the University of Texas Southwestern in Dallas, followed by 2 years of fellowship in undersea and hyperbaric medicine at Duke University. Until 2013, she was a professor of medicine at the University of Texas Health Science Center in Houston, where she initiated the Memorial Hermann Center for Wound Healing and Hyperbaric Medicine and the Lymphedema Center. She is now a professor of geriatrics at Baylor College of Medicine in Houston. She serves as Chief Medical Officer of IntelliCure Inc., a health information technology company, and is the Executive Director of the U.S. Wound Registry, a nonprofit organization recognized by the CMS as a qualified clinical data registry. The USWR develops wound-relevant quality measures and helps wound care practitioners meet the requirements of Medicare's quality payment program. She's currently serves on the board of Alliance of Wound Care Stakeholders. She's the past co-chair, and CU Global. And she is the American Diabetes Association Amputation Prevention on the Amputation Coalition. She's co-chair of the Real World Evidence Work Group for the Wound Care Collaborative Community. Past board activities include American Academy of Wound Management, the Association for the Advancement of Wound Care, and the American Professional Wound Care Association. She is the clinical editor of Today's Wound Clinic and has authored more than 100 peer-reviewed articles and book chapters, as well as editing 3 textbooks. Her research contributions include the development of real-time lymphatic imaging with Dr. Eva Sevic using near infrared technology, and more recently, the use of real-world data for comparative effectiveness studies to understand what works best for patients with chronic wounds and ulcers. Thank you so much, Dr. Fife, for
Oh
joining
my
us
gosh, Karen, I
today.
didn't know you were going to read all that before.
I know. It's so exciting. We're so happy to have you. Welcome. And in addition to Dr. Fife, we also have a Dr. Nancy Collins. Dr. Nancy Collins is a wound care certified registered dietitian nutritionist based in Las Vegas, Nevada. She is known nationally for her expertise in the complex relationship between malnutrition, body composition, and tissue regeneration. Dr. Collins has over 25 years of wound care experience in a variety of care settings, and she has treated and healed hundreds of patients. In addition, she has published over 100 articles in wound care journals, including Wound Management and Prevention and Advances in Skin and Wound Care. She has presented nutrition topics at every major wound meeting, authored 6 textbook chapters on wound care nutrition, and has served on multiple advisory boards. Due to her expertise in wound healing, Dr. Collins is often retained as a medico-legal expert. She has consulted on over 500 medical malpractice and wrongful death lawsuits involving non-healing wounds. Currently, Dr. Collins is the Academy of Nutrition and Dietetics representative to the Alliance of Wound Care Stakeholders and a member of the Malnutrition in the Elderly Work Group for the Evidence Analysis Library. Welcome, Dr. Collins.
Thank you so much. I'm so happy to be here for kind of a different type of webinar rather than just listening. We're going to have some good discussion today.
I'm so excited. I think this is the first time that we've done both sides of the coin with a physician and a dietitian, looking at how nutrition is impacting and is interweaving through the wound care process. So without further ado, let's get started. So, when we're looking at our objectives today, as we discussed, this is a different format, but we're looking for the attendees to gain insight on how nutrition intervention is becoming more critical in accelerating wound recovery and improving patient outcomes in such a diverse in diverse healthcare settings. We know that it's wound care and wound management impacts, especially in the U.S., all areas of um, all areas of intervention. So we're talking about acute care, post-acute care, outpatient care, and then what can we do at home? How can we assist in making sure that throughout the entire cycle of this wound process, we are doing what we can to help support these patients? So topics of discussion today, we're going to go through a couple of things, but we will be discussing with both clinicians on how to improve the impact of nutrition in wounds. So let's talk a little bit about the specific nutrients. Excuse me, I apologize. Let's talk a little bit today about the significant advancements in wound care technology. What do you feel, Dr. Fife, are the most significant advancements in wound care technology and practice that you anticipate for 2025?
Well, we've had coverage with evidence development for platelet-rich plasma. And so I think that's a technology to watch. It's going to be indicated, or it's covered now for diabetic patients, but it doesn't have to be DFUs. It could be the broad spectrum of all of those wound types. The introduction of AI is going to be a big deal, whether that is just used at the moment for clinical documentation or whether it's to improve the interaction with the patient, or whether it's actually going to drive selection or recommendations remains to be seen. But it's possible we're going to start seeing some clinical suggestions be generated by analysis of data from charts. So that's going to be interesting to watch. And I'm sure I'll think of some other things, but I'm curious to know what Nancy's thoughts are about this.
Well, I think that the biggest thing in practice that I see changing after like 30 years of doing this is that I think that nutrition is finally getting its due. It's finally, we have enough evidence. I think nutrition in general is a pretty young science compared to all of the sciences. And, when I used to go to the library and, you would be able to get on the computer for an hour before everyone had it at home, there was hardly any studies at all. The evidence is coming out. And, I have a couple of things to share with you as we go on here about some of the new evidence that we have. But I just think it's exciting for me as a dietitian that nutrition is finally kind of coming into its own and really playing a more active role in wound care in general. I think, most of the clinicians now understand that if you don't have the proper nutrition on board, it really doesn't matter what
What you do.
technology you're using or what you're doing on the outside if someone doesn't have the nutritional substrate from within to build new tissue.
And I think there's something else important to bring up, because it's not just advancements, because the advancements sort of, I don't know, it implies something new and different. But the fact is, all the technologies that we're using, then now all the payers, Medicare especially, but all the payers are deciding whether they're going to pay for things based in part on whether appropriate standard of care has been met. And nutrition is something that Medicare auditors and all of these entities are now looking at in a very serious way and telling doctors, you can't do these things until you've addressed this. So I agree, Nancy. I'm sure it's just because it's following the evidence, but that is a big deal for payment policy now. Nutritional assessment is part of payment policy now.
Very interesting. And as dietitians, we know that nutrition plays a pivotal role in a variety of, interventions and management of disease. But Dr. Fife, you mentioned previously on, some of our calls and discussions that you're paying more attention to nutrition in your practice. Can you tell us a little bit more about what you've been looking at more closely from a nutrition perspective in wound care?
I am so embarrassed I have to play two true confessions, because I have known Nancy forever. I've heard so many talks by Nancy, and I have ignored a lot of what she has been saying for decades. Nancy, I'm so sorry. I'm glad I get to apologize to you publicly.
This is what I was saying. Nutrition has been like the stepchild. Now, you weren't the only one ignoring me, but I was still out there, trying my
I'd
best
like to give
to the nutrition's horn.
a huge apology to
But
Nancy.
now it's getting a lot of attention, so it's good.
So I just want you to know I finally listened. And and maybe we'll have a chance to talk about this. Um, uh, Doctors need things to be simple, not complicated. Maybe I shouldn't insult all physicians with my perspective, but the thing that I realized is that I had to recognize this was a problem and do something that was within my capacity as a humble family practice doc to do. And so I asked myself, what are the simple things that I could do without later we might have a chance to talk about why I don't get to talk to Nancy or one of her colleagues for most of my patients. But I said, all right, I can implement a screening tool. They're very accessible ones. I happen to love the Nestle MNA. I guess we get to use words like that since this isn't CME. I looked at them and said, oh, look, there's something that's quick and easy and it gives a number. So that works well with my simple girl philosophy. I realized, and maybe we'll have a chance to talk about this, but I realized that vitamin D deficiency was one of the major things happening in people with non-healing wounds, particularly surgical dehiscences. And that is something easy to diagnose and cheap to fix. And then I said, the other thing that I'm going to do is start giving everybody L-arginine. Maybe we'll have some time to talk about why L-arginine is no longer the pinnacle, but that's the message that I finally heard. I said I can do three things. I can screen, I can check vitamin D levels and get people started on enough supplements, and I can give them over-the-counter L-arginine supplements, which are indicated for just about everybody with a boo-boo, except maybe people who are with really significant renal impairment. So that is what I decided that I could do for everybody. Maybe we can talk about how that worked out for me, but you asked me what I did, and that's what I did.
That leads us into our next question. So we're talking a little bit more about what are some specific nutrients or dietary patterns that you have shown or have shown you the most promise in promoting wound healing. So you mentioned vitamin D.
So vitamin D was a big one. And this is Nancy's fault. And I'll tell you why it was Nancy's fault. And, by fault, of course, I'm complimenting her. So I've been the clinical editor of Today's Wound Clinic, and Nancy wrote an article about vitamin D for Today's Wound Clinic. And as the clinical editor, I was editing the articles right before they got posted. And so this is a true story, standing in the hallway, reading her article just to make sure it was good to go. And the next patient I walked into was not this patient, but almost identical scenario. So she wrote an article about vitamin D and how important it was. I walk into the room and it's this poor woman who's got juvenile diabetes. By now she's in her late 30s. She's been sick all of her life. She failed a knee replacement because the wound dehisced, another knee replacement, and then she was on negative pressure and it wasn't working. And so I walk into the room and I looked at her and I thought, I feel like something's been missed here. And oh, by the way, I'm fair-skinned, but she looks like uncooked fish. And so I said, do you ever go outside? When's the last time you were outside? She said, outside, like outside? I said, yeah, like outside. And she said, it's been 2 years since I've been outside. Sure enough, her vitamin D level was in the single digits. I supplemented her. She'd already had 2 operations and had therapies that weren't working. And as soon as we got her vitamin D level up, she healed. So this was the next patient I saw, which happened to be the pictures that we chose. And although there's a little stretching of the picture, this is a very sweet man. And I posted this picture online because at the bottom of that wound is a pulsating dorsalis pedis artery. That's the top of his foot. He'd had a podiatric surgery, very simple procedure. It popped open, and I saw this thing, moving in the wound bed, and I thought maybe, he had a muscle fasciculation, and I realized it was a pulse. So this is a man whose vascular supply is so good, I could watch the artery of his foot pulsating in the hole. Ooh. So we know that he has enough arterial supply because I'm watching the artery move. And that's, by the way, when you say, okay, well, we're not going to debride anything here because don't touch it. And the only real thing, and the black Sharpie is underlined, is a sort my outline of the undermining. You could take a Q-tip and tuck it under the skin for that area that's about the size of the palm of my hand. The only thing I changed for him was to fix his single digit vitamin D level. And the next picture is the beautiful granulation tissue that he made with my little probe is showing there's no undermining. Like I did one thing for him. Everybody wanted to do fancy stuff.
Mhm.
You know, they could have put in skin subs. We could have done a vac. We could have done all kinds of things. He needed one thing. He needed some vitamin D. So those were two cases that really set me on the, oh my gosh, I've been missing this for 30 years. Maybe I should listen to Nancy.
And that article is readily available online. I think if I remember correctly, the title of it is the Sunshine Vitamin.
Sunshine Vitamin.
Right. And it lists all the levels for supplementation and repletion and diagnosing deficiencies. So if you think that you're maybe missing vitamin D also, I would recommend that you download that article from today's wound clinic. And, you can get, more detailed information on vitamin D specifically.
And it was just perfect timing because I had just read the article and walked into a room and said, oops, maybe this is what I've been missing. I do want to make a comment too about wound care. You know, that old story about when they, in the 20s, when they asked Willie Sutton, the bank robber, why he robbed banks. And he said, because that's where the money is. One of the things about non-healing patients with non-healing wounds is if you want to find people that probably have a nutritional deficit, they will be the patients with chronic non-healing wounds. That's really where the money is. I don't know anything about nutrition really, and I sure don't know about patients with other medical problems, but I do know that they are in the waiting room of the wound center because that is a major reason why people end up with non-healing wounds. So it is worth it to draw labs to look for things. You will likely find them. I don't know that that's true across the board, but it certainly is when it comes to wounds.
I think you make a great point too, Dr. Fife. All the more reason, like you are seeing a variety of patients, a plethora of them in the wound centers. But I can't guarantee, but I would guess that the majority of our audience are seeing these patients when they are presenting in the hospital for other comorbidities and challenges. All the more reason that we should be addressing these nutritional deficits early and aggressively and be able to help guide them for nutrition intervention so that way we can assist with that wound healing process as soon as possible.
And, I just want to point out too that we're not just talking about inpatients, we're talking about outpatients. If you have a boo-boo that isn't better,
Right.
the likelihood is we have a clinic full of patients who've been starving under the watchful eye of their family, not because people don't love them, but because they were just missing it.
Oh yeah, there's plenty of room in the sandbox to play with everybody. We are very inclusive here, right? Dr. Collins, when we're looking at specific nutrients or dietary patterns, what do you feel is one of the most promising to promote wound healing?
Well, obviously protein is king in wound healing. And, also as we were discussing, sometimes people think they're eating well, but they're not really eating designed for wound healing. So I have a perfect example here. My sister-in-law just, she's 22 days post-op today with a knee replacement surgery that is not healing already, right? And I told her, you have to eat a lot of protein. You have to up your protein. And she said, well, she's doing that. So I asked her, what did you have for breakfast? And she said, a bagel with margarine. And I told her, I said, there's no protein in that. I said, and what are you having for lunch? She said, well, she had just a sandwich, 2 slices of bread with a tiny little bit of tuna in it. And, so she thinks she's, eating. She said, I'm eating enough. And she doesn't want to gain weight, of course, because, she wants to, she's pretty thin. She doesn't want to gain weight. But she's definitely not having nearly the adequate amount of protein that it's going to take to heal. And I think that a lot of patients, even when, she's obviously living at home and relatively young, when I look at the patients in the nursing home as well, they have tea and toast for breakfast, which is no protein at all. That's all they're having. Or they have a little bowl of oatmeal. And then the same thing, the little half a sandwich for lunch. And you're just going to have to, as the clinician taking care of these patients, be aware of that. And you're going to have to design some sort of plan to meet these elevated protein needs of these patients. It's not going to happen without some sort of a detailed plan laid out on how you're going to do this.
And I always feel very humble talking to Nancy because she's the real expert. And another confession, in medical school, one of the two subjects I hated the most was anything to do with nutrition. Like I could fall asleep instantly. It's like a huge Ambien. I was never interested. So it's very ironic that where I am at this stage in my career is caring so passionately about this subject. But to think that I would have ever begun to take dietary histories from patients, like never in my wildest dreams would I have believed that I would ask patients to write down what they ate and bring it in so I could look at it. And indeed, that's exactly what the typical diet is for a patient with a chronic non-healing wound. It is a Danish, a sandwich, maybe a bowl of soup, some cookies, and then I'm not hungry after that. So that is a huge problem.
Dr. Collins, you mentioned protein, but how do you feel about amino acids? We talked a little bit briefly about arginine.
Right. So I think that, again, this is, over the years, of course, things evolve. And, I remember the days when I used to go around nursing homes and giving out, whole milk and graham crackers was our intervention. And then we went to, canned things and, things move on. And I don't know, maybe it was 15 years ago, we found out that arginine was really crucial to, the wound healing cascade because that's the precursor for making nitric oxide. And you need to have arginine on board. So then we, of course, stressed arginine. And probably that's when Dr. Fife started realizing, well, I'm hearing
I started
a
to
lot about
listen.
arginine and it's obviously crucial. And now things have even gone to the next level. So now we're talking a lot about citrulline. And I know some people probably are not even familiar with citrulline because when you see those list of the 20 common amino acids, often citrulline is not even on that list. But citrulline is another amino acid, but it really only has a limited role in the body. But its role is very key to wound healing. Its power is that it gives rise to arginine. And I know this is, somewhat confusing because how could something else be better than the actual thing? But it turns out that citrulline is even a better way to bring arginine on board because of the way it is metabolized and how it the duration of it and how it goes through the digestive tract without a lot of it being lost in what's known as the first pass metabolism. And so citrulline is something that's not only being studied for wounds, it's what else needs blood flow? Well, a lot of things, everything from exercise and endurance to erectile dysfunction to heart disease in patients with diabetes, anything where you need extra blood flow, citrulline is one of the topics that is being heavily researched. You can see there's just a couple of these studies on your slide, but in wound healing, we now have this new generation of products that has citrulline in it as a way to bring the arginine on board in a very efficient, longer lasting manner. Instead of giving a big bolus of arginine, as long as citrulline is present in the bloodstream, it will continue making arginine. So it has a lot of benefits of giving the citrulline. So again, this is just, shows you that the science just never stops. It just keeps moving in the same manner as, we don't use the same insulins we did 10 years ago. We certainly have new generations of antibiotics. And now we're getting into this new generation of nutrition intervention for wound healing, which, of course, is just following the science along.
Nancy, do we need to spend a little time for you to explain what is the point of nitric oxide?
Sure, if you'd like to.
Yeah, I think
when you have this obviously to build new tissue, you have to have neovascularization. You need to bring blood flow to this new tissue in order to keep it alive. And nitric oxide helps bring that increased blood flow to the tissue. And arginine is what is used to produce nitric oxide. So in order to have that blood flow to keep the newly built tissue alive, you're going to have an adequate supply of arginine. And, there's a whole cycle where obviously arginine, then there's something called arginase, which breaks down arginine to ornithine and urea. And citrulline is something that even tempers that arginase so that more of the arginine stays on board for a longer period of time. So, it's rather a complex mechanism, but what you need to know practically is that newly built tissue needs blood flow in order to stay alive. And arginine
diabetics are deficient in it. I was at UT Houston, and Fred Murad and some others won the Nobel Prize in 1998. He was at UT Houston discovering nitric oxide as the mechanism that capillaries have to decide if they're dilating and to distribute blood flow appropriately. And so, I was at the place where the discoverer of nitric oxide and its importance. I was at that institution, and still, we just were not talking about what it takes to get in his department, even, and we were not talking about what it takes to make sure that patients had enough nitric oxide.
Right. And like I said, it's not only in wound healing that people are studying this. I mean, to me, one of the most exciting studies here is in that corner, the one that's looking at type 2 diabetes and citrulline. Obviously heart disease is increased in patients with diabetes. And if there's a way to get that more under control with something as, simple as citrulline supplementation, that would be, obviously great to all these people that have diabetes.
And I don't know if this has been backed up with clinical data yet, but when I started becoming very militant about L-arginine, because that's what I knew to do at the time, about a third of the patients I see in the wound center have heart failure, really dramatic heart failure, and their ejection fraction started to improve. So I was working on their wound, but lots of other things started to get better, with the primary measures being all cardiovascular.
Yeah, so it's very exciting.
Yeah. And one of the other things, I do want to move on, but one of the other things that I've heard, Dr. Collins, you mention is the contrast intolerance that we're aware of, at least from arginine supplementation versus citrulline when we're looking at things like higher levels of supplementation. Can you briefly discuss that?
Well, I've always had patients who told me they don't want their supplements. And of course, you try to drill down and figure out why they don't want it. And often the answer is it gave me diarrhea, it gave me a stomach ache, it didn't agree with me, it made me nauseous. I mean, variations of the same thing. And that can be from a large bolus of just straight arginine.
Right.
Whereas with citrulline, it doesn't tend to have that effect. So it's better tolerated. So if you're having someone who is not taking their supplement or following their regimen because they're complaining of, GI issues of any sort, citrulline can be something that can help you tackle that, as it's because it's just digested in a different manner.
Right.
And I did see this in patients with ostomies. They're having to wear a colostomy bag. And as I'm saying, look, you got to take some of this stuff. The answer I sometimes got is it puts gas in my ostomy bag, so I just can't have that. I didn't know about citrulline at the time, or that would have been the solution.
Well, I mean, it gives you, obviously, there's no one size that's going to fit every single patient. You have to find what someone's willing to accept and stick with, because it's going to take weeks for a wound to fully heal. This isn't, you take one and you're done. You're going to have a plan.
But they may see a difference within 2 or 3 weeks. In other words, they may be able to see measurable changes in their ability to heal before the actual closure. So people can get a lot of encouragement within a month or less.
Right. And then that becomes motivating to them. They think, oh, this is working. Obviously, if you think something's working, you want to stick with it. If you think it's not working or making things even worse, then people tend to drop it.
I mean, that makes complete sense, though,
Absolutely.
So let's move on. Let's talk a little bit about how can healthcare professionals better educate patients about the importance of nutrition in wound care. Dr. Collins, I'm going to throw this one to you first.
Well, I think that obviously it depends which setting you're in, because as Dr. Fife alluded, sometimes you have a dietitian available, and in some settings like outpatient, you typically do not. So, it's going to depend where you are. Obviously, in long-term care, and even acute care, there's going to be a dietitian available. So you can, always include in whatever your protocols are in that facility. Maybe the dietitian sees every patient with a wound, or if you're short dietitians, maybe it's every person with a stage 2 or higher wound. Maybe you'd skip the ones, when you're talking about pressure injuries staging, that is. But I think also for people on the outpatient, we're in an age today where you can just go on the internet and there's so much information. You don't know what's accurate, what's not accurate, what's a hoax, what's quackery. So I think also you have to tell the patients to know the source of the information that they're following, because there's a lot of people wanting to sell you a lot of things on that internet. And, in outpatient, I try to always, I speak at these wound meetings to educate the physicians. And again, not that they're going to become the dietitian or the nurses are going to become the dietitian, but while you're doing a dressing change or while you're doing a home visit, if you're doing a home care, it's very easy to open the refrigerator for a moment and see what's in the refrigerator. If it's just, I've done that because I have worked home care before, and there have been refrigerators that only had like beer, ketchup, and mustard in it.
So that sounds like my refrigerator. Yeah.
Nothing. So you have to wonder, well, what are these people, eating? But during a dressing change, you can say, what did you have for breakfast? That's a simple question. You have to start somewhere.
I want to add to the importance of the physician and the nurses being on board. I started this little project in my own little clinic, and within maybe 2 or 3 months, the nurses and I were seeing such dramatic, we were seeing people heal who were on hospice who weren't getting enough protein and calories if we just got them on L-arginine supplementation. So I can only imagine what citrulline would have done. And they got so excited that I could hear them starting the nutrition education before I got in the room to meet the patient for the first time. I could hear them say, while we're waiting for Dr. Fife to come in, we just want to talk to you about some things that impact wound healing. And for me, I don't know if this is a useful thing, is remember, I'm primarily outpatient based. I talked to the rep at my hospital and said, can you get me samples of these things? Because patients are going to have to buy them when they're an outpatient. That is a huge barrier. These things are not cheap, no matter which one you're talking about. And I wanted to be able to hand patients a sample and say, I want you to try this because it really tastes good. And you're going to have to commit that you're going to buy this and take it for at least a month. And then if it doesn't seem like, if you can't tolerate it or you're unhappy after a month, we'll regroup. But for at least a month, this is what we're going to do. And once they have tried it, so many things began to get better that I never had anybody say, that's it, I'm not doing this anymore. Everybody gets on board because, especially in wound care, when something starts to work, you can see it.
That's a great point.
I think that's a good point. If someone has tried it and they know that it's something they're willing to do, then of course they'd be more likely to buy it. So sampling.
Otherwise, on the outpatient side, they got to go to Amazon and invest what is not an inconsequential amount of money for an outpatient. And of course, the same economic argument can happen in long-term care because somebody's got to buy that and make it justifiable on the per diem. So, cost is a barrier, even though we're not talking about dramatically expensive things. They're not usually going to be billed to insurance.
That makes sense.
And when that's the case, by the way, let's face it, if your doctor told you, I believe in this and I think that you'll get well or at least better if you do this, I just can't think of anything. I have doctors too. If they said, I believe in this, and I go, you know what you're talking about. So once it is actually something that the clinicians know is working, that's what I had to get to listen to Nancy. It just wasn't enough to have Nancy, talking to me at meetings. Once I did it and believed it, then I didn't need Nancy to follow me around clinic. I could be my own advocate to my own patients. And then they get on board and then they tell their friends. So that's the other thing that I saw happen.
If you get success, do more of it, right? I mean, absolutely. So let's move on. I introduce you both to our audience. You clearly are both heavily involved in research. You're have done quite a bit of work when it comes to research and publications. Let's turn to some research that has recently been published. What are some key research findings that have shaped current practices in wound care and nutrition? I'm going to go to Dr. Fife first for this one.
So Nancy has finally gotten the message across, just about the message across about L-arginine protein, some of those other things. But here's what worries me, and this may not have been the answer you were hoping I was going to give you. So much of the research, particularly around nutrition, is in pressure ulcers, pressure injuries, whatever we're supposed to call them today. But in fact, that's a very small segment of the world of chronic non-healing wounds. With one of the things that gets missed is that the most common wound type in Medicare beneficiaries and the most expensive is the dehisced surgical wound. Lots of people don't realize that. So I get it about why so much published research is in pressure ulcers. And my friends like Nancy, who are such evidence-based, methodical people, are often a little afraid to color outside those lines. But if you say to me as a doctor, what's the chance that nutritional supplementation of pressure ulcers will be completely irrelevant to every other kind of wound? I would say, I get it. There may not be a publication in every wound type, but I'm sorry. It's highly likely that it works across the board. So I'm going to let Nancy pick up on the theme in terms of very specific trials, but I just want to throw out there that even if most of them do tend to be in pressure ulcers, it is not. I do not feel comfortable with people saying, "Well, I don't want to talk about those other things because there's no paper published about it." Nancy, I'll let you tackle that.
Yeah, no, I agree that obviously basic nutrition is basic nutrition, whether you're building tissue to heal a surgical incision or you're building tissue to heal a pressure injury. But most of the studies are in pressure injury. So there was one new study that perhaps you haven't seen because it's pretty darn recent. And I think that in nutrition, we're usually used to outcome studies where we have two groups, we give one intervention, the other group, the other intervention, and we see which has a better outcome. But there's another whole area of research that we just haven't had in nutrition called health economic outcomes research, right? And so this study is an economic study, which is a modeling study where they were looking at wound-specific oral nutrition supplementation. This is different than the standard high-calorie, high-protein. These are products that particularly are enriched with extra ingredients known to help with wound healing. And they wanted to know, from an economic standpoint, is it worth the nursing homes spending additional funds on these more costly products, or can they just go with the standard of care? So if we look at the next slide here, again, this is an economic model. This is how these studies are done. They take known facts about a various topic, and then you can manipulate these facts in a modeling sense and determine whether there's going to be benefit. And of course, as Dr. Fife said, somebody has to eventually pay for these items. Nursing homes are under, of course, the patient-driven payment model and value-based purchasing. Is there value? Is there an economic value to spending money on nutrition that will pay off perhaps in other areas? So this study really looked at that question and built this very complex model that used, statistical analysis to show you whether this was a good buy or not a good buy. And so they looked at pressure injuries, and they looked at a typical nursing home, which was, according to research, is an 85-bed nursing home. And they looked at this over a 1-year period. And then did the modeling to see if you to look at the normal amount of patients in that setting who have pressure injuries, and you give them the standard of care or you give them the wound specific, what would happen? And so when they looked at that population over this 12-month period, they were able to say that, well, what if we spend $2 to $3 a day extra on nutrition? Would that be a good value or not? And it turns out, of course, that it is a good purchase because it was able to improve healing times and 50% shorter healing times when they use the right ingredients. You're not going to get that citrulline in a standard product that's going to give rise to that arginine. You're not going to get the dipeptides in some of the newer products. So using that specific wound product healed it faster. And when you heal something faster, of course, that's going to lead to cost savings. If you're taking care of the wound for a much shorter duration of time, it's going to save nursing hours and it's going to save money. And so that is a good buy. You're investing a small amount in nutrition, but now we have the evidence that shows that it pays off big time on the other end. So it is a good value. And the reason I bring this up is because sometimes I speak to administrators who say, well, we already have so many products on the formulary. Do we really need another product on the formulary? And the answer is yes, you do when it comes to wounds. You should be using a wound-specific oral nutrition supplement at this point in time. The evidence is there that supports that. I have another study to show you that it supports it from the outcome to the value. Here's another, recent study here where they looked at not only amino acids, but what about peptides? Are there any specific peptides, which are short chains of amino acids, that would be implicated in the wound healing process? So for instance, if you had 3 amino acids, that we would call that a tripeptide. If you had 2, we would call it a dipeptide. And what this study did was, this is a double-blind, placebo-controlled study, and you can see the design on the next slide. 16 weeks, 120 patients, 112 completed the study, and they divided these patients into 3 groups. Okay, so of course, one is the placebo, and then one group got a low level of collagen dipeptides. For short, we call them PO and OG. It's prolyl hydroxyproline and hydroxyprolylglycine. So these are dipeptides, 2 amino acids bound together, and they gave one group a low level of this and another group a higher level of this. So like, for instance, if you're using any sort of just a typical protein supplement, you would have kind of a low level of this. The wound-specific products like Expedite are highly concentrated in the amount of PO and OG. And then they did some typical wound outcome measures, push scores, pressure ulcer scale of healing, and PSAST scores, the pressure score, the pressure sore severity tool. And when we looked at, I'll just show you one of them because the citations there, you can easily read this. The push scores, in a push score, a lower number is better. The red boxes are the 3 groups before, the yellow boxes are the 3 groups after the treatment. And you can see that the group that got the high levels, the more concentrated levels of PO and OG, were the ones that had the only statistically significant improvement in their push scores. So again, making the case for this wound-specific oral nutrition supplement. So we know that you need individual amino acids in the form of citrulline, and you need the whole protein. You need to be eating more than a Danish for breakfast, and you need a concentrated level of these very wound-specific dipeptides, PO and OG. And when you put all that together, this is how you're going to start seeing healing, like Dr. Fife says, even in patients who possibly are on hospice, who think that there's no possibility of healing. You have to give them the substrate from which to heal.
I want to also point out, I know your next topic is patient engagement, but in the outpatients, we have to make an economic argument to them too, because they're the ones that have to buy it. And you think about all the things that come out of pocket when a patient is being taken care of, whether it's their co-pays for their doctor visits, whether it's the co-pays for their medications, whether it's out of pocket or expenses that come out of their deductible that are their dressings. That same it'll save money argument, which is really what the health economic model is It will go faster. You won't have to come in as often. You will be done sooner. This will help you. Those are arguments that work for an individual person, just as they might work for an institution.
And the one thing that we never really ever have the opportunity to mention, and I just feel like obligated to mention this, is that a lot of these wounds are painful. And getting someone out of pain in an era when it's very hard to get pain medicine,
Yeah.
it to me is just very important, because so many of these people, even people, that I just know in my own life, they can't sleep, they're in pain. My sister-in-law literally called me today in tears, crying. I don't know what to do. It hurts so bad. Um, you feel bad for these people. My heart hurts for them. If we have a way that we can get these people to heal 50% sooner, I mean, that's very important.
Now, one of the things, I know this is a sidebar, but one of the big problems for somebody like Nancy's sister-in-law after knee replacement, they have so much swelling. And a major contributor for swelling is the third spacing that happens because people don't have high enough protein levels. Their albumin drops. And then that's one reason they get edema of the tissues. And edema is the most common diagnosis that patients with chronic wounds have. They have swelling. And in many cases, it is because their protein levels in their blood are too low. So it can't just be with the one thing. We have to be sending that broader message, but it certainly is true that once we get people convinced they're going to feel better, they will do it.
All really great points. And Dr. Fife, you started alluding to this previously, but as we know, for any nutrition intervention to be effective, it has to be consumed. It has to be adhered to. We have to make it easy. It has to be cost effective. We have to get the buy-in from the patient. And it often needs, when we're looking at wounds, to be done consistently over several weeks, perhaps even longer. How can we improve patient engagement and adherence to nutritional recommendations in wound care? Can you possibly, we'll start with Dr. Fife. Can you share some of your experiences that you have worked on with
So one of the
your
things that I've
population?
always noticed is especially an outpatient, most elderly people, although they're patients like my mom who are 99 and can drive, but she also doesn't have a wound, they usually have some family member with them.
Yeah.
And that family members are watching them suffer, just as Nancy mentioned, and they want to do something and they feel very helpless. And when I say, look, here's something you could do, you could make sure that this is available and that it's taken every day. This is your homework assignment. That is an actionable task that is, nobody is against better nutrition. Like there's nobody that you're ever going to talk to who's going to say, well, I just don't think that'll help. There's just generally, when you're talking to patients, a general understanding that somehow there are things that are going to be good for them because they take all kinds of supplements, some of which are no good and not helping them. They spend, in many cases, a lot of money on stuff that's crazy that they saw on TV that is not really going to help them with wound healing. So sometimes it's the family, but a lot of it I discover is my attitude. If I believe that something is working, then it's amazing how much my attitude, if I'm like, oh, it's an eye roll, like here's Nancy, someone like Nancy going to talk about nutrition. I'm like, oh, whatever. Then that is also a bad message to be sending. The clinicians have to be on board. Everybody has to know that this matters and that patients will do it if they are convinced that it's going to help them, and especially if they've tried it so they know that it doesn't taste bad. That's probably the next most powerful thing, is nobody wants to take something that's disgusting.
Good point.
Absolutely. And so, again, I know people, I always just call it as it is. I think people know that about me, who've heard me talk before. So a lot of times people ask me, well, why am I using so much expedite now? Well, because it's so easy for the patients. With the just twist open the bottle and it's ready to go in just this very small 2-ounce portion. That's something that just seems easier for the average patient. And it's such a small amount, 2 ounces, that even if people don't absolutely love it and think it's the best tasting thing they've ever had, it's one or two sips and it's over.
And they're done. They don't have to mix it. They don't have to stir it. They don't have to shake it up.
Right. There's no preparation, once a day, no muss, no fuss, easy and and effective.
I think that's powerful. I will say one thing about patient engagement is I'll say this on behalf of physicians. If anybody is nervous about talking to physicians, I assure you, most of what you've probably said to a doctor went above their head. We are simple creatures. We need simple interventions. You know, physicians have a lot of stuff on their mind, and if anything, the struggle I had was coming up with something simple enough that I could just do it. And I realized that that may not be perfect, and that there are patients that an expert should see because they're complicated, because they have renal failure, because they have all these other issues. But if I am seeing people in outpatient, then the likelihood is the majority of those, I could make a simple recommendation and try it, and no one's going to be hurt. And what fascinated me when I started talking to physicians about screening patients as part of our CMS approved quality measure, this surprised me so much. Nancy, a physician said, what if I tell them the wrong thing? What if the advice that I give them is not right? It's like, oh my goodness, we've in some ways, by elevating this conversation, have made physicians feel like it's too hard for them to do something. So if we could just help physicians understand there is something very simple that you could do that's not bad for anybody except maybe this tiny subgroup, just try it. You don't have to have somebody to do a consultation just to try this thing. I think that would be a big step forward in trying to get more patient engagement so that you could reduce some of the complexity and fear factor of physicians who are like, I don't know anything about this. I don't know what to do. Give them something simple and this is it.
Absolutely. Yes. I think that to me, I don't know, just the small serving size is just so key because, you know, I go in and out of patient rooms and you just see it sitting there hour after
Yeah,
hour.
sitting there.
No one has consumed it. And
You
then
know, we didn't talk
where
about
does it go? Down the drain.
We didn't talk about contraindications. Nancy, is there anybody for me as a clinician that I'll say, okay, but not you? You're one of those people who can't take a little swig of citrulline.
No, and the expedite bottle has sugar in it, but one carbohydrate exchange. So I mean, it can easily work into a diabetic. The expedite also comes in a gelled, like a gelatin type cup, which is safe for patients with dysphagia, and that is sugar free. If someone is totally, against sugar, you have another option. So really, it's wide use. Sometimes with the renal patients, we always talk about vitamin C for wound healing also, but renal patients can't really have a lot of vitamin C if they tend to form oxalate stones and things of that nature. So there's not additional vitamin C in here. People are typically getting a multivitamin or some other type of supplement, so they're usually covered that way. So it's good for the renal patients as well. So really, it's a wide usage.
What I heard you say is there are really no
Correct.
contraindications that as a doctor, I need to be afraid of this somehow. So I think that's a powerful thing for the nutritionist to be able to do. The first thing a physician's going to ask is, who can't have it? Can I screw this up? Can I hurt somebody? And the answer is no. Just try this.
Right. It's basically protein. And people are eating food, they're consuming protein. This is just concentrated in a way that you're getting a good efficacious dose of the ingredients that we know build new tissue in a small 2-ounce bottle or cup.
That's a great explanation. Thank you for that.
Perfectly put. We shockingly are almost out of time, so let's close this out. I can't believe we've been talking for almost an hour.
I have to say that went very fast.
Yes. Last question here for both of you. If you could make one prediction about the future of wound care, I'd love to be wound care specific to nutrition, but I'm just going to be general here. The future of wound care, what would it be?
More people have wounds and they're going to be treated more in the outpatient setting.
Okay, well, I read something just the other day that kind of, I don't know, stunned me. That there's 63 new diet drugs under development. 63. So these GLP-1s, people are losing a lot of muscle mass, and they're never going to heal in certain circumstance. So I don't know. I just think the future is going to be about weight loss drugs. It's just everywhere. And I don't think that people realize, maybe perhaps at this point, the full implications of taking these drugs. And what if you're taking these drugs and you're going to have surgery, or you have a heart attack and you have a cabbage, and you've lost all this muscle mass? I mean, I just think it's going to further complicate wound care.
So it's a really powerful thing in general for people that may be taking smaller meals for any reason,
Yeah.
is that every mouthful has to count. So that is, as we have more and more people with complex medical problems, that making sure that what you put in your mouth counts with something that's really going to make a difference. That I think is a powerful message to send, especially to people who don't feel good and don't really feel much like eating. Let every mouthful count.
I mean, that's so true. It's like, how do you tell somebody who already doesn't feel well, that they basically have to take in another, liter or
Drink this
so?
great
Yeah,
big can of something.
yeah,
Twice a
yeah.
day.
Yeah, twice a day. Yeah. And I've even had patients with anorexia nervosa who, of course, had wound healing problems. And, they were sort of chronic anorexics. But as Nancy had mentioned, they're afraid of gaining any weight, even to the point that they aren't taking, in my opinion, enough calories at all. But I love the fact that these are powerful things for wound healing with very few calories, not just very little volume. So that I was able to say to this woman, look, you're not going to put on an ounce. You just need to take this and your wound is going to get better. She's like, okay, well, I'm on board if that's the case. So there's a lot of challenging patients out there, and there's really no part of this story that they can't be on board with. We've managed to negate most of the complaints that they're going to have around this idea.
Absolutely. I mean, it's clear with the discussion today that nutrition and wound healing go hand in hand. The research continues to emerge about the benefits of the topic and the need for additional intervention. I thank you very much today, both of you, for your participation. This has been so exciting. We do have a couple of questions that I'd like to address too. If you don't mind, we'll take a few more minutes to push through some discussion points. So one of the things that came through was when we're talking about the benefits of either citrulline or arginine, are there any specific dosing guidelines to adhere to when we're looking at recommendations? Dr. Collins, I know we've talked about dosing guidelines. The question does say the dose of L-arginine and other items. Can you allude to what the research says there in regards to its benefits?
Well, when we look at the studies that just use like pure arginine, a lot of them are in maybe the 6 grams to 10 grams a day type of study. Citrulline is lower because it works in a different manner. So it's more in the neighborhood of, what would you say, maybe about 2 grams to 4 grams, in that neighborhood.
Yes. The research that I've seen is anywhere from 2 upwards of 6 grams
Yeah.
when we're looking at nitric oxide production.
So I don't think that if they're kind of, that makes me feel that maybe they were alluding to, could people get too much of this or something?
Right.
I think that you're not going to exceed what's going to be safe for a patient, and no one's going to sit down and drink 10 bottles of expedite in a day. If you use it at its recommended usage, 1 to 2 bottles a day, you're going to be perfectly safe and fine.
Absolutely. And then when we're talking about L-arginine, I know specifically for the NPIP guidelines, the 2019 guidelines did discuss the utilization of L-arginine, but they don't necessarily give specifics regarding how much. And then
Right.
you did discuss when we were talking about how too much arginine can actually cause gas and GI distress. I know one of the articles that they cite in there actually talks about the impact of a dosage of 4.5 grams of arginine versus, I think it was 9 grams of arginine. And there was actually no clinical, statistically significant difference
Difference in
in the
taking
small,
more.
yeah,
Right.
in the
Sometimes
smaller
more is
dose.
just more. It's not better.
Right. Um, One of the questions that the clinician actually wrote says, do you need a physician's order for expedite? And I can answer that. Expedite is actually a medical food. So while it is designed to be used under medical supervision, you don't need a prescription or a physician's order for it. We
There
should
may be
be
an order and a sniff. Maybe somebody has to say it's okay. I can see that.
Absolutely. And the same thing will go for any oral nutrition supplement. You do have to have, when we're looking at provision of care, you do have to have a medical order if we're looking at a facility-based intervention. But from an outpatient perspective, there is no specific script for any requirements. One of the other things that did come up, Dr. Collins, that I don't know if you want to discuss are contraindications for the pediatric population. If you don't want to discuss, I'm happy to when we're looking at expedite.
Well, I will leave that to you because I
Perfect.
don't think I've seen any studies in that area
Right. So
lately.
the product is designed for the adult population. So it would be post-puberty, ideally 18 and above. When we're looking at the pediatric population, L-citrulline actually hasn't been studied enough to be cleared for the pediatric population. Not that there is any risk of harm. So it is just like most other wound supplements. It is not intended for the pediatric population. So the utilization would be under clinical discretion.
I have a question for you while you're talking, Karen. If someone has never tried Expedite or this is the first they're hearing of it, can they use some of this contact information to get a free sample?
Absolutely. So we do have information here um, on the screen. If you are interested in learning more, feel free to drop us a line at info@medtrition.com. You can visit our website, or for specifics regarding Expedite itself and what we have to offer, including research, case studies, sample requests, you can go to expeditehealing.com. I will also include with a follow-up communication from this session. Some of the links were the research that Dr. Fife had discussed as well, just so you have easy access to some of those things, as well as the research that we cited looking at our discussion today. That takes us to my time, Eastern 7:02, and this will conclude our session today. Thank you both so much for your time. This was really fun. It was a great way to kind of get information out there, talk about research, and I loved having you, Dr. Fife, on here to talk about the importance of obviously medical intervention and nutrition. And then Dr. Collins, it's always a pleasure to discuss your expertise as well.
If only I'd listened to Nancy 10, 20 years ago. Sorry,
Well,
Nancy. Better late than
everyone's
never.
listening now. It's an exciting time. And again, we're facing what the New Year's is, Christmas, I think what they say is 41 days away. So we'll be in 2025 and hopefully everyone will be reinvigorated and rejuvenated to set up some protocols and try some new things in 2025 and get those patients healed. Set new goals for yourself.
One of my favorite sayings is that it's what you learn after you know it all that counts. And
Very.
so I appreciate Nancy teaching me something after I thought I knew it all, because I didn't.
I mean, that's what it's all about. We're always learning, we're always growing. Science is always changing, so there's always something
And it's
something.
harder to keep up when there was only one or two nutrition studies in a year. It was
Yeah.
easy to read them. Now they're coming out quicker. It's hard to keep up with everything.
Well,
Very
thank
much
you
so.
both for the education that I got tonight. I appreciate it. And thanks everybody for attending.
Thank you so much. Take care, everyone.
Bye bye.
Bye.